And now we can go ahead to welcome the next speaker, Dr. Shambo Samrat Samajdar, who will be again dealing with another area of gastroenterology, and that is, I think, is it okay, Dr. Shambo? You can project your screen and introduce your topic, please.
Thank you, sir. So
Is it
actually, it is my real honor to share the ideas with my mentor, Professor Santanu Tripathi sir, and one eminent gastroenterologist in the city, Professor Banerjee sir. And it is really challenge to me because, and also it is very much, I may say, it is a proud of mine that I am sharing this after talk of my senior Dr. Rahul Jainda and my friend Dr. Prateik Poddar. Actually, we all know in cricket, specifically the test match, after having two wonderful opening batsmen, sometimes we need to face night watchman. So hopefully this night watchman me will play good little bit. So let's come to the topic. Hopefully my screen is visible. Is it okay, Rohan? My screen is visible. Rohan, can you hear me?
Yes,
Hello?
it's visible. It's visible, Dr. Shambo.
Okay. So for next 15 to 20 minutes, we'll discuss about adherence to inflammatory bowel disease. And for that, we'll more focused on the different immunosuppressive agents. So this will be my flow of discussion, little bit overview of therapeutics, then coming to the adherence to therapy. What is the definition of adherence? What are the effects of non-adherence, specifically while talking about inflammatory bowel disease, and how we can improve adherence. So while talking about inflammatory disease, it is important to note that it is an immune-mediated disease, chronic in nature. We can see two broad categories of inflammatory disease. One is ulcerative colitis and another is Crohn's disease. And how it happens, in our gut, there is one T regulatory cells which mediates FOXP3 and make our immune system regular, or we can say functional, so that the food item, when it reaches gut, our gut will not act with that food item like a foreign substance. But what happens when this regulatory system becomes dysfunctional? Our mucosal immune system becomes reactive, and there will be some inappropriate innate immune sensing, which causes activation in the CD4 T cells in lamina propria, and there will be different T cell mediated mediators that come into the picture. So Th1 cell secretes interferon gamma, Th2 cells secretes interleukin 4, 5 and 13, and Th17 cells secretes interleukin 17 and 21. So while talking about disease, we need to understand the target, because if we not find the target, then we will not get our weapon, that means therapeutics. So here few important targets. Initially, in the leukocytes, the receptors on the leukocytes, the alpha 4 beta 7 integrin, which helps the leukocytes in adhesions, and that is one pathologic features of inflammatory bowel disease. Apart from that, addressins on vascular endothelium like MedpeR1, and this receptor tells us the importance or giving importance on coexisting thrombotic natures in our system while we are suffering from inflammatory bowel disease, to take care on that. And then the Th1 cytokine pathway initiated by IL-12. So we need something to reduce that expression of interleukin 12. Apart from that, interleukin 4, interleukin 23 and interleukin 6 induce the Th2 and Th17 cells. And what happens? There will be the activation of macrophages which secrete two important cytokines like TNF alpha and interleukin 6. There is one friend in our gut, that is interleukin 10 and transforming growth factor beta. If they are acting in a regulated way, they helps in by preventing inflammation. So coming to this picture, the inflammatory cascade in IBD, and what I want to give emphasis on the gut microbiota. So normally we have good gut microbiota, but due to some environmental influences, we can say bad influences, there will be alteration in the gut microbiota composition, and which happen to be a detrimental step in producing this inflammatory cascade by stimulating that TLR and causing activation in the dendritic cells. So that dendritic cells, there will be no regulation by the Treg cells which induce FOXP3 by deactivating that dendritic cell. And what happened then? Ultimately, there will be more Th1 and Th2 cell expression, production of different inflammatory, pro-inflammatory cytokines like interferon gamma 4, 2, 13. Here 10 means what happened? The activation of this dysregulated system causes some changes in the interleukin 10 receptor. So here the good interleukin 10 behaves like a bad interleukin 10. And apart from that, other pro-inflammatory cytokines like TNF alpha, interleukin 12, interleukin 23, which activate macrophage, and macrophage becomes activated. And they cause the mucinous layer impaired. So we have some inflammation or autoimmunity. So here also there is the focus how the other inflammatory cytokines are going to disrupt that tight junction in that epithelial cell. So there is a disruption of tight junction, there will be bad microbiota enters, so the vicious cycle of autoimmunity started. So here we can understand the friend is only Treg and FOXP3 that producing interleukin 10 and TGF beta, which helps to prevent inflammation. Otherwise, all these inflammatory cytokines like 4, 5, 13, like 1, 6, 12, 23 and TNF alpha, all those happen to be bad, or we can say enemy to our gut, and they are responsible for that alpha 4 beta 7 stimulation. Again, we should remember that is another target for different drugs which helps in leukocyte recruitment, and that perpetuates the inflammation cycle. So this is very important to understand, because after knowing the target, we can select our weapons. So this is in one slide we can say the different weapons we have, and the weapons we need to prescribe to our patient. Along with, if we know our target, we know our weapon, we can discuss this with our patients in the layman language, so that patient can understand the importance of each drug. So for biological agents, we have adalimumab, we have infliximab. They generally block that TNF alpha things. There are some leukocyte apheresis, or we can say that alpha 4 beta 7 integrin level things. So that is generally mediated by certolizumab, or sometimes that we can say the abatacept, like that. There are some inflammatory modulators like azathioprine. There is an importance of antibiotics because there are some bad microbia like Escherichia coli, they and some anaerobes, they cause some trigger to this disease. And for that, to take care of E. coli, we have ciprofloxacin. To take care of anaerobes, we have metronidazole. The other biologic agents like anti-TNF alpha, we can say that the adalimumab already we had discussed. They are generally used for ulcerative colitis. The infliximab, abatacept, adalimumab. Vaccine has some theoretical role. We need to have more studies on that. And probiotic lactobacillus has some role. Inflammatory modulators like mesalamine, they have some beneficial role in ulcerative colitis, and theoretical role of vitamin D, growth hormones, ZAC3 inhibitors, naltrexons are explored in case of ulcerative colitis. Now, coming to one case, that 30-year-old Mr. AN, about 3 weeks ago, experiencing a crampy right lower quadrant abdominal pain, increase in frequency of bowel movements to 5 to 6 times per day. Abdominal pain became worse after consuming a meal and was partially relieved by defecation. There is anorexia, which is increased in nature, 8 kg weight loss, mild fever, tender abdomen, presence of occult blood in loose watery stool sample. So these are the lab results. Hematocrit is 26%, hemoglobin is 8 gram per TL, WBC count is raised, ES are raised, sigmoidoscopy, lower colon and rectal biopsy not giving any clue to any disease, stool samples negatives for Clostridium difficile and parasites. Baria minima suggests there is some presence of an edematous ileocecal valve and terminal ileum. Endoscopy suggests cobblestone appearance of the GI mucosa of the terminal ileum, which with some areas of diseased tissue separated by normal mucosa. So the diagnosis was made by gastroenterologist. It was a Crohn's disease, but while eliciting history, it was found that this particular person was suffering 5 to 6 episodes like this for last 2 years, occasionally taking antibiotics like ciprofloxacin, ornidazole fixed dose combinations, sometimes ofloxacin, ornidazole combinations, or metrogyl tablets as over-the-counter medications. One time he had visited to one physician. That physician had advised some tests, but no investigations done. So this is very important because while we are talking about any disease, this is the main adherence issue happened when the patient starts ignoring his symptoms and ignoring the advices from physicians. So we need to take care of that. And now coming to the therapy in whole, these are the different types while choosing different therapies to inflammatory bowel disease patient. We have to classify. There are some classifications. We are not going in details about that. Mild variety, moderate variety, and severe disease. And for mild, we can use topical corticosteroids, antibiotics like ciprofloxacin, metronidazole, or aminosalicylates. For moderate, we need to use, we can use immunomodulators, oral corticosteroids. But for severe disease, we need to, biologics. And for treatment responsive ones, we need to stuck with aminosalicylates. There are some theories nowadays, and I think 2021, there is 2020, there was a guideline made by American Gastroenterology Association that using biologics from early stage, which can prevent further progression or not. So there are some guidelines are there. I am not going in details because that is not today's discussions agenda. So coming to adherence to long-term therapy, because there is we are convinced that inflammatory bowel disease is such a disease which requires long-term therapy. And now, while defining adherence, it is important to note that the extent to which a person's behavior, taking medication, following a diet, and or executing lifestyle changes corresponds with agreed recommendations from a healthcare provider. So that is adherence. So we always use one term, compliance, along with adherence, but there are some difference between adherence and compliance. While taking classes and while going to patients and taking history of them and suggesting some therapy, I remember my two professors. One is during my MBBS days, Professor Ardhendu Sinha Roy sir, and during my DM training, Professor Santanu Kumar Tripathi sir always tells us, while teaching or while seeing patient, be a coach to your patient or be a coach to your student, not a teacher or just not an advisor. So what happened in the in any game, in games like football, coach is there to help or guide the players. So we have to execute that role, and for that what is important, that agreed recommendations, this agreed terminology is important. So for adherence, agreement is important. So this is an agreement between me or we and our patient. So that when the patient is agreed to continue this, so that is the adherence. And adherence means in that there should be active participation of patient. Otherwise, there will be no adherence. But for compliance, coaching is not there. It is only to see. So there is no agreement between patient and doctor. So we always need to give emphasis or while treating our patients on adherence, not only talking about compliance. So patients' agreement to the recommendations is very important. So here the patients are active partners with health professionals in their own care. So we can involve patients in their own care. So now coming to the inflammatory bowel disease and non-adherence rate. So it has been seen in Asian IBD patients, the non-adherence becomes 20% to 30%. And among the young adults and pediatric patients, the non-adherence rate is around 17% in young adults, 5% in pediatric patients. So pediatric patients have less non-adherence, so they are more adherent. There is obvious reason for that, we all understand. And for biologics therapies, specifically the anti-TNF alpha therapy, the non-adherence rate is between 6% to 14%. So we can say, as this is very important to note, that the persons who require biologics, they have some better adherence rate. But again, this should be this is very much dependent on the context of the patient, the availability of the drugs. These are the issue, the financial things. So it is important to note the other factors also. Now coming to non-adherence in inflammatory bowel disease, what is the effect of non-adherence? So there will be increase in disease activity, more chances of relapse, loss of response to anti-TNF agent. So this is very, very unfortunate, because we know that anti-TNF agents are costly. So if this happens, loss of response, so that is very unfortunate. The non-adherence is directly correlated with higher morbidity and mortality. There is more chance of colorectal cancer in a non-adherent IBD patient, increased health expenditure, poor quality of life, And as there is one specific index, inflammatory bowel disease disability index, that also the high disability score is correlated with poor adherence or non-adherence. So there are some other issues while talking about adherence to therapy, or we can say the immunosuppressant therapy in inflammatory bowel disease. So there are multiple drugs we already discussed. So while we are choosing ASA based therapy, our patient need to adhere to folic acid supplementation. So that is very important. Patients who are on glucocorticoid therapy, they should be adequately informed about the importance of tapering of glucocorticoid dose. While we are prescribing azathioprine, it is essential to be adhered with this practice of monitoring complete blood count and liver function test. Even with methotrexate therapy, it is important to go for testing with CBC and LFT. And sometimes the hypersensitivity pneumonitis is very common with methotrexate therapy, and we should be taken care of, and our patients investigation protocol should include to exclude hypersensitivity pneumonitis by investigations. While the patients are on cyclosporine, it is obvious to adhere to check blood pressure, creatinine level, to screen for opportunistic infection, and sometimes we need prophylaxis against opportunistic infections like pneumocystitis, carinii, pneumonia, like cotrimoxazole therapy. Monoclonal antibodies are very important, and as already we had mentioned about non-adherence means there is a more chance of failure to monoclonal antibody, and one of the reason is that if we are not prescribed, or if we are not adhered to appropriate dose and frequency of monoclonal antibody, there will be increase in the development of antibodies to these monoclonal antibodies. So there are some protocols to increase the dose of this type of monoclonal antibodies and reduce the frequency of dosing, so that we can overcome to that antibodies to different monoclonal antibodies. There is a chance of lymphoma, and if we go by the side effects in the prescribing information of all monoclonal antibodies, there are chances of lymphoma. But this increase the fear among our patients. So we need to discuss this matter with our patients. We need to talk with our patients with all relevant data, whatever they can understand. Otherwise, they will not adhere to therapies like monoclonal antibodies, because they will go for internet checking. They will see this monoclonal antibody associated with lymphoma, they will stop taking it. So this is a very important thing to note, that how we can assess the risk, how we can make understand our patients about the risk and benefit of monoclonal antibodies in a balanced manner about lymphoma, incidence of lymphoma. Now, talking about pregnancy and lactation, that is very important to note also, because there are some patients who left therapy, and there may be in remission phase, but again when they becomes pregnant, they will have a flare up of the disease. So we need to educate our patient that if you become pregnant, then there is a chance of recurrence. So you need some therapy, and we all know drugs like sulfasalazine, mesalamine, balsalazide, they are safe in pregnancy and lactation. So what is important when the patient is in active phase, there is symptoms, so the patient will come to the doctor, and patient will seek for advices and drugs. So the healthcare seeking behavior is there when we are symptomatic, but when our symptoms gone, so healthcare seeking behavior gone, we become non-adherent. So we need to address this issue very holistically, otherwise there will be problem. So now while prescribing therapy, it is also important to measure adherence. Otherwise, whatever therapy we are prescribing, that will not act, because drug will act only if we take that. So there are some methods like direct method and indirect methods. Direct methods means measurement of levels of different metabolites. Indirect methods are there like pill count, pharmacy refill, electronic monitoring devices, and some patient self-reported questionnaires. Now coming to each portion, I will be brief in that. Like estimation of different drug metabolites, just one important molecule is azathioprine. We know that this is a steroid sparing agent and it maintains remission in both ulcerative colitis and chronic disease. Now azathioprine as a prodrug rapidly cleaved to 6-mercaptopurine in the liver, and now 6-mercaptopurine via enzymatic pathway, they will produce 6-methyl-mercaptopurine and one active metabolite known as 6-thioguanine nucleotides or 6-TGN. This 6-TGN can be measured. So there is a significant correlation that if the 6-TGN level between 235 to 450 picomole 8 into 10 to the power 8 RBC, then that is highly correlated with good clinical response. And when we are talking about thiopurine non-adherence, that means if it is less than 100. So therapeutic drug monitoring of this type of metabolites can increase the efficacy, patient safety, and cost effectiveness of different other biological agents also like infliximabs. But there are some drawbacks associated with therapeutic drug monitoring. What is, we all know about white coat hypertension. Here we are talking about white coat adherence. What is that? It is improved patient adherence to treatment around clinical visits. So I am taking 6-mercaptopurine or ASA drugs while I am going to visit my doctor and while giving blood, so that will not reflect that I am not taking drugs for last maybe 1 month. I am taking drugs for last 15 days. So this is very important area and a drawback for TDM. This is a direct method, obviously. So it has some cost and labor intensive methods. Other drugs like methotrexate metabolites in treating IBD patients, the usefulness has some question marks. While using mesalazine, we need to measure 5-ASA and N-acetyl 5-ASA by GCMS or LCMS. So they are little bit costly affair, but we can measure that also. There are easier things or indirect methods of measuring adherence like pill count. What is pill count adherence rate? That is equal to number of pills dispensed minus number of pill returned divided by number of pills prescribed multiplied by 100. So that gives the pill count adherence rate. So this is a simple, objective and inexpensive method to see the adherence. But sometimes it overestimate or underestimate the adherence. If I am not taking the drug, just taking the drugs and that the drug not enter into my system, that cause some overestimation, and sometimes it may cause underestimation also, that how much number of pills I am returning to patients. And it is sometimes difficult in our settings also. The patients who are coming from poor socioeconomic background from villages, it is little bit difficult and it also takes some time. Now pharmacy refill data, so they used medication possession ratio and proportion of days covered method. So this is a popular methods in US, but we know that in our pharmacy we don't have any data. So what is medication possession ratio? It is defined as the proportion of days supply obtained over refill interval or fixed interval. And what is proportion of days covered methods? that defined as the number of days covered over a time interval. So it generally assumed that patients with an MedpeR or PDC more than 80% are classified as adherent to their treatment. There are some electronic monitoring devices also, like medication event monitoring system. Medication bottles contain some microelectronic chip, so registers the date and time of every bottle opening. So I am opening the bottle, it is registered. So provided that each bottle opening represent medication intake. So otherwise, again, this will not serve the purpose. It is expensive and no guarantee that the medicine which is removed is actually consumed or administered correctly. There are some self-reporting things like patient kept diaries, patient interviews, and some standardized validated questionnaires. So this is one very popular scale, 4-item Morisky medication adherence scale we will find in the net. So we can understand the score and we can judge about the adherence. Apart from that, there is a IBD specific validated 8-item Morisky adherence scale. So while treating our inflammatory bowel disease patient, we can have this scale and we can score them and we can understand the adherence level in those patients. So these are the very simple question we can ask the patient, and as per that we can calculate their adherence. So how to improve adherence? So number one is education. So education has very importance here. And as we are starting with some talking about some pathophysiology, so pathophysiology is also very important. While talking with our patient, if we can make them understand about little bit of disease pathology in their term, in layman's term, so that can improve adherence. So etiology, pathology, anatomy, investigation, medical surgical treatment, mechanism of action of the medication regimen, dosing schedule, potential side effects of the treatment, and we should also ensure them not to be worried about that, and when they need to be worried. So everything we need to talk. And we also give focus on consequences of non-adherence, disease course, the risk benefit of using drug and not using drug. So risk of using therapy and risk of not using therapy. Importance of nutrition and other complications of IBD, we need to educate our patients. When patients require surgery, so that also need to be focused while giving some therapy to the IBD patients, because that fear of colectomy that may increase the adherence. So behavioral intervention is very important. Shaping, reminding, or rewarding desired behavior. So that also known as reinforcement. So cognitive behavioral therapy that use the principles that negative thoughts can block the abilities to act and learn new behaviors. So consume medications at the prescribed time or refill medicines. So we need to talk about these not believing medications could alleviate symptoms. Also, we need to talk about that we need some medicine to continue. Otherwise, your autoimmunity again will trigger, and that will produce different symptoms, which sometimes you may require surgery also. We need motivational interviewing, telemedicine with subtypes including telemonitoring, tele-education, teleconsultation, and telecare. That also improve adherence. And some pharmaceutical modifications is also important. So just like an example, that if we all know that when we have polypharmacy has a more chance of being non-adherent. So if we can address that issue, polypharmacy, that can help us. So once day formulation of mesalapine by using some technology like multimatrix system that release mesalamine in the colon, incorporates mesalamine into a lipophilic matrix within a hydrophilic matrix encapsulated in polymer resistant and to degrade at a low pH less than 7, and that causes delay release throughout the colon. So this type of modifications will be helpful. So coming to my epilogue, that we should be very simple while prescribing any drugs to increase adherence. So number one, we should simplify the regimen. S for simplifying the regimen. Number two, impart knowledge or informed prescribing. M for modifying the patient's belief and behavior. P for provide communication and trust. L for leaving the bias, and E for evaluate the adherence. So it is not only, we should also give emphasis in revisit, when patient will come for revisit, regarding what happens to the adherence after our intervention. So evaluating adherence is very important, and here we need to give on another importance on another E. That E is empathy. So we should not blame, we should not shame our patient if we found our patient to be non-adherent. So we have to address this issue little bit in a empathic attitude. So with that, I thank you once again for giving me this opportunity. Now I can, if we have some discussion up now, I am open to it. Over to you, Chairperson sirs.